could be very, very valuable with this pandemic that we're dealing with. Especially when we think of the second wave, which we're seeing in Canada. We're only just starting to see it here in British Columbia, but already we're seeing increased hospitalizations, increased visits to the intensive care unit, a small but still significant increase in death rate, more severe, more susceptible, and potentially dealing with more disabled. So I really feel that we need to know what these individuals are suffering from. Okay, Nick, if you can give me a hand here. We've got the first slide, but we cannot advance.
We can't get rid of it. Okay.
We've screen saved. It's got to go up to the top.
I think you should be able to use the arrows on your keyboard.
It won't move.
It won't move.
It won't move? Okay.
And we've still got
That's strange.
down the side. Can we move them out?
Sorry, is the
Participants, Tom.
the camera images?
Yeah, the camera image. We can't get rid of those.
Okay. Does that help
You
you?
need to get up here.
Nope.
Open the slideshow.
Oh, it's open.
How about those arrows at the bottom left-hand corner of the screen? Is that?
Oh,
There you go.
Okay, great. Thank you very,
No
very
problem.
much, Nick. Using Zoom all the time, but for some reason. But certainly the greatest concern is with the more severe cases who've been hospitalized. The issues are involving the brain and central nervous system, pulmonary, and cardiac. In terms of the central nervous system, the individual suffers an inflammatory storm, and patient's own immune system responds in an exaggerated manner. It produces this cytokine storm. And it was only in June of this year that corticosteroids, particularly dexamethasone, was advised to deal with this cytokine storm. The virus also stimulates megakaryocytes, and if you're looking at those that can go, think back to their hematology, they're the cells that increase platelets, leading to an embolic storm. The treatment for this initially was aspirin and heparin, and now anticoagulants is the recommended treatment as of June. Individuals can develop, because of these emboli, acute ischemic stroke, encephalopathy, and impaired consciousness. It is obviously one of great concern. The end result is much like what we've seen with concussion, and it's closely related to Parkinson's. And as you know, that's the condition involving the basal ganglia, where the individual is left with an altered gait because of a loss of dopamine, impaired balance that we need to deal with as physicians and therapists, neuromotor dysfunction, and falls. There's recently been the Stanford Hall consensus statement for COVID-19 rehabilitation. And for those that progress from there to a psychotic state, again, corticosteroids are strongly recommended. The longest follow-up that we have seen in the literature comes from China, probably no surprise. 27% had depression, 42% suffered a post-traumatic stress disorder, 13% recurrent headache, 16% dizziness, 10% of peripheral neuropathy, and 2 persistent nerve pain, neuralgia, and 10% musculoskeletal symptoms of recurrent muscle joint pains and swelling. And then a small amount with epilepsy, encephalitis, confusion, cognitive impairment, but a very severe condition, which they were the first to report on, a post-infective myelitis with acute flaccid paralysis. The investigation for increasing concerns about neural problems are MRI and angiograms to identify the amount of infarction or emboli within the brain, and brain scan. And in terms of with the management of these individuals, where we've said that there has been a degeneration of dopamine, and dopamine controls motor function, motivation, pleasure out of the basal ganglia. And early on, individuals, because of the close nature to Parkinson's, Tai Chi in the early phase has been effective. Yoga, boxing drills have been incredibly effective with these. Working on an elliptical unit, the intensity, we have to identify as therapists and physicians that sweet spot where it's difficult enough to challenge the individual, intense so they're sweating, and complex enough that it engages their mind. And the biggest thing that we want to do is there is a brain-derived neurotrophic factor, which is stimulated by exercise, particularly moderately intense exercise, and using large muscles like your quads, your pecs, your hamstrings. And this increases the release of a muscle growth factor that turns on this brain-derived neurotrophic factor that increases blood vessels, which they have lost with COVID, and increases new neural pathways. And the intensity recommended is 70 and then increasing to 80% of your max heart rate, starting at 15, progressing to 40, and then ultimately to 60 minutes. And for those individuals that in fact have Parkinson's, where we have much more experience, obviously, than we do in terms of COVID, an 8-week study showed 3 times a week at 80% of maximum heart rate for 40 minutes. This increased dopamine expression by 80 to 90%. In other words, you saw a increased production of, of dopamine. So this can lead, and we will talk later, there's a large number of individuals that continue to have neural challenges, and we'll talk about that in a few moments. Now, in terms of the pulmonary involvement, the lung, again, they see this inflammatory storm. Again, the megakaryocytes are peppering the lung with pulmonary emboli. The individuals get a pneumonitis or inflammation in the tissues between your lobes. This then becomes fibrotic or stiff, and there is a mild to moderate restrictive pattern seen at 6 to 8 weeks following the infection. So when you're working with a patient at 6 to 8 weeks, all of a sudden they're getting more shorter breath, they are having difficulty breathing, talk to that team or the individual's physician to get lung function tests done to see, in fact, how much restriction we're seeing in the pulmonary structure. It's very interesting with the lung itself with COVID. Some will collapse acutely with a low PO2, less than 90, but many others are asymptomatic and are just die. They get what they are describing now as a happy hypoxia. Breathlessness is not triggered in the COVID-19 patient until the PO2 is less than about 88 to 90. And it's because of that, the recommendations now are, and we should, if you're monitoring these individuals, it would be worthwhile to get them to purchase a home pulse oximeter. When they get to 93% PO2, they should be hospitalized because, as I say, this breathlessness doesn't occur. And it can be a shock to you and the individuals in hospital. So these individuals should be monitored during rest and with exercise itself. In terms of the medications, as of February, the antiviral agents, and the one that is most commonly used here, and it was just approved 2 days ago, actually, it's being used here now since July in Canada, but it was approved officially by Health Canada, and that's remdesivir. And so these antiviral prevent patients from becoming severely infected before they go to hypoxia. The big concern is once these individuals, if you have to put them on a respirator, they may survive, but they have more ongoing pulmonary issues. And if you're working with the individual that does become shorter breath, they do much better if you're having them lie prone. In Israel, in May, they identified an agent called alpha defensin, produced by the patient's own white blood cells that causes microclots purely in the blood vessels in the lung. And this can be prevented, and Dory will be very familiar with this agent. It's an old anti-inflammatory we use primarily for gout, and that's colchicine. And that has been very effective in clearing the lung of these microclots. And this is produced by the individual's white blood cells. So we get the inflammatory process, which overstimulates our immune system. So we get more inflammatory problems. We get the megakaryocytes generating more platelets. So we're getting clots in the brain, clots in the lung, and also, we'll get to in a moment, in the heart. And at the same time, our own white blood cells are producing this agent, which is causing microclots in blood vessels in the lung itself. So the investigation for a return to sport then is a chest x-ray, which is clear. To identify the inflammatory reaction, they're recommending a CRP, getting spirometry done to ensure that their lung function is good, and a max VO2 with oxygen saturation with exercise. Now remember, these are the individuals that are the more severely affected individuals. But unfortunately, with the second wave they're seeing, the prediction is, and from what we're seeing out of Ontario and Quebec and in other places that have got the second wave, that we're seeing more of this pulmonary restriction. If it persists, then an MRI of the lung or a lung scan. And the recommendation for these individuals is once they feel they are better, no exercise for 10 days is the current recommendation. Then if they're symptom-free, a graduated return to exercise, starting with light activity, walk, jog for 15 minutes. And then, as I mentioned, 70% of maximum heart rate for 2 to 3 days. Then 80% of maximum heart rate for 30 minutes, gradually increasing that every second to third day by 10 minutes. Return to the previous level if they have any difficulty. So if they do at 80%, you drop them to 70 and you drop them to 20 minutes. There is, right now, there's not a SCAT equivalent for COVID. This material I've been able to obtain from the American Cardiology. I've been on a number of their webinars and with our SportMedBC. And when we get to the cardiac group, they are very interested in taking over. We've applied for a large grant. We have also applied for a grant with Silk Cresswell with the chronic brain program that I was lucky enough to get $1 million for about 4 or 5 months ago out at Alan McGavin. And so if they have difficulty, you move back. Then 2 to 3 days later, we move on. And the whole message is go slow, be gradual, and when in doubt, investigate. Now, in terms of the cardiac issues, and this is the one that we're most concerned about, not that those, the CNS and the pulmonary concerns weren't bad enough, but it's the cardiac issues that again can be quiet, and then the individuals will have problems. And it comes to that inflammatory storm. It results in a viral myocarditis. Does this occur? And Dory's probably familiar with the 20 National Football League players that currently have a viral myocarditis from COVID. So in terms of the age, it's not just the seniors. It results in myocardial injury and death of heart cells. It results in hypotension, low blood pressure, hypoxia, both lung and cardiac induced. It alters the receptor of the ACE2 receptor, hence the hypotension. And the other big concern are arrhythmias, irregular and quite a plethora of arrhythmias that can result. So it's a result of these pro-inflammatory mediators and hypoxia. You get vascular inflammation in the coronary arteries. The myocarditis and acute cardiac injury can be determined by cardiac biomonitors, high sensitive troponin for the physicians, beta natriuretic peptide, and cardiac failure can certainly occur. And that's shown by decreased left ventricular stroke function that you would see on an echo. And again, this is the result of these increased activity from the megakaryocytes and increased platelets, and they get clots in their coronary arteries. The arrhythmias, tachycardia, your heart rate is much higher than you would normally expect, particularly supraventricular tachycardia or ventricular arrhythmias, ventricular extra beats. They can get a high-grade atrial ventricular block. They can look at and see ST elevations, and you can also see T-wave inversion. This is typically associated with ischemia or a heart attack. Pathological Q waves, again, you're wondering whether this individual has had a myocardial infarction. No, it's because of the effect of the virus on the muscle itself. You get a bundle branch block. You'll see the QRS, which is the voltage from the heart muscle, is low. And individuals are wondering, is that because they've got a pericardial effusion and that's why the echocardiogram is critical? Or is it myocardial edema? And they can show features of right ventricular strain, and that can be associated with these T-wave inversions. So the investigation before you want to take anybody out and exercise that has had any issues in terms of their heart, they need a 12-lead ECG. They need at least a 24-hour, if not 4 or 5 day Holter. They need that echo to see if they're going into heart failure. The lab, again, look at the inflammatory markers, the release from damaged heart cells, high sensitive troponin and beta natriuretic protein, renal function, and the hematology, particularly to be looking at the high level of platelets. The investigation for these individuals, they should all have an exercise stress test. In my mind, if you've got, I would be sending them all to Sport Cardiology BC and Saul and Jimmy and the team there. They may just get a MIBI scan to look at areas that have decreased oxygenation to that portion of the heart itself. And to document myocardial injury, they'll get a cardiac MRI to look for the late gadolinium enhancement. So that this is serious. These individuals that have been in hospital and you're exercising them and they have low blood pressure and a high heart rate, ensure that they've had an exercise stress test, ensure that they've had an echo, and ensure that they've had a Holter. If they're slow to progress, where initially they were symptom-free, but then on their graduated return to exercise, you start to get concerned about them because their heart rate now all of a sudden is higher. This could be 6 to 8 weeks once you started them, much like where they had the restricted breathing pattern because of the fibrosis. And this is the increased exertional dyspnea. They've got elevated rate of perceived exertion and elevated heart rate at submaximal exercise intensity. So for these individuals that really do have documented myocarditis, the current recommendation, both from the European and the American cardiology, is it's at least 3 months that they need complete rest. Many, depending on the severity and if they've got evidence of failure, where they've got a dilated heart, you can see on echo, they need monthly ECGs, Holters, echo, and the lab work. And for these individuals, once their left ventricular systolic function, their left ventricle is pumping properly, you've got to make sure those serum markers, the troponin and the beta natriuretic protein, they have a normal 24-hour Holter and a normal exercise test. So I'm not sure whether you can see this. This is a very effective graduated return to play along the lines of what I've talked about. It came out in the British Journal of Sports Medicine June 22nd of this year. And for you that are working with them, perceived exertion is a real useful tool that they've identified in those, and it's not big numbers, but in those individuals that have got, back to exercise and the psychological readiness to return to sport. Do these individuals feel psychologically they're ready? And regardless of the coach, regardless of their own drive, if psychologically they don't feel ready, they're not. And so that this process itself, from the time you start them, you're starting them at 15 and then up to 60 minutes, 80% maximal heart rate, and then you can then get them into sport-specific training. So that is a summary of those individuals, and hopefully you're not going to see a lot of them. But for those individuals that you do see, check their balance, check their mental function. And because there's a group, and there's 3,000 in Greater Vancouver with symptoms over 6 months. They call themselves the long haulers. They feel as if there's no help available and they're all alone. And on September the 17th, they opened a clinic on the 5th floor of the Burrard building at St. Paul's. So if you've got individuals, send them there. We have been talking to them from Alan McGavin about handling their exercise return. There's 3 studies now in Ontario on the long-term effects. And for the last slide, what do these individuals, these long haulers, complain of? Fever, a return of fever, significant headache, muscle pain, the myalgia, tachycardia at low exercise and low blood pressure. They feel lightheaded, fatigue, persistent neuralgia, nerve pain, shortness of breath, poor exercise capacity. And I know I've seen and I've talked to a few, and these individuals who have been very good runners or top cyclists, triathletes, at 6 months, they have difficulty climbing stairs. They have a loss of short-term memory. And the thing they describe, and this is reminiscent of those individuals you see with a concussion, this brain fog, the fuzziness. They may present with seizures, and it may have endocrine changes in terms of thyroid, hair loss. So that these individuals, and as I say, there's 3,000 in Greater Vancouver, that this doesn't go away in a short period of time. These have had these symptoms for 6 months. So I hope that doesn't frighten you. I hope it makes you think when you're seeing these individuals, and remember that window, that time period of 6 to 8 weeks where they may have been slowly progressing, but then all of a sudden they're going south. And you really need to be tied in with a cardiologist or the family physician in terms of getting pulmonary function tests, and to get those markers of ongoing damage, particularly from the heart, and see what the hell those platelets are doing. Have they been stopped to this point? The antivirals early on appear to reduce those, the accelerated megakaryocyte production of the platelets, but not a guarantee. So I will stop there and answer any questions that you may have.
Okay, so at this point, Jack, you'll take questions. And I think people should just speak up and ask their questions of Jack. I just want to point out to you that we're 32 people on the screen when we started this presentation, and there were 32 when Jack said, I'll take questions, which is pretty cool. So any questions?
Thanks, David.
So if you want to ask a question, unmute and ask your question.
Jack, Mark Rizzardo, I just wanted to congratulate you. That was a really good summary and actually pretty informative for me.
Mhm.
Thanks, Mark. Since I've been doing this, and I've been talking to a number of groups, about this, we just need to have this kind of knowledge in terms of our rehabilitation of these individuals, because it's not like we first thought. It was like getting over the flu or another viral complaint, and they're going to be fine in 2 weeks. That's not the case.
Jack, Kim Cormack here. I'm not sure if I missed it, but what would be your indication of who you would decide to send for the extra cardiac screening? What would be the indication of needing that?
For cardiac screening, for like
Mhm.
cardiology?
Yeah.
Right. Those would be individuals that their heart rate is much higher than you would have expected from if you knew them from before, or you just had them in the clinic and you were doing relatively light exercise, and all of a sudden they got a heart rate of 130. Their blood pressure is low. They feel short of breath, and they have postural hypotension. When they stand up, they feel dizzy.
Okay.
Those individuals need to have an exercise stress test. They need an echo. So for anybody that has spent any time in hospital with this disease, they need, as a minimum, an echo, a stress test, the troponin, markers, and you really want to, before you embark on more intense, exercise, you want to make sure you get those basic, and a pulmonary function test.
Great. Thanks.
Are there any other questions of Jack? So one of the things I'll just say is that, and I hope I have this correct, Jack. All of this has been recorded, and it's my understanding that you're very comfortable with people accessing your slides. Is that the case?
Yes, that's right.
Okay, so
You can put them on your website. You can.
yeah,
We want to spread this.
no, I appreciate that. Thank you very much. Okay, well, thank you so much, Jack, and it's just sort of comes at the right time. So I appreciate that, and it's wonderful to have you here with us today. So
Well, again, David, congratulations, and congratulations to the 5 that were elected today. And Sarah, it's great to see you, involved, as you've been involved so long with our darling sport. But it's great to have you back in terms of SportMedBC.
okay, well, I think we're sort of finished. Does anybody else have any questions or queries they want to raise at this point? Okay, well, hearing none, I think I'll bring this meeting to a conclusion. And thanks so much for hanging in there. I think we have as many people pretty much at the end of the meeting as we had at the beginning, and I'd say that's a pretty fantastic, I think, in terms of the annual general meeting and the Jack's presentation. It's something to be proud of. So thanks again for your time and your evening, and we'll.
And thank you, Nick, for getting me through those opening.
Yeah, my pleasure. I didn't have to do much.
And so, and we have to, again, I just have to say, we have to thank Nick so much, because the Zoom such an unusual medium, such an unusual platform to work on, and I'm not entirely sure. I heard an educational theorist who said that actually Zoom was not designed for this purpose. It was designed for other purposes, and we've kind of adopted it or adapted it. So we owe a lot to people like Nick who make sure that everything kind of unfolds in kind of the way it should. So thanks so much, Nick. I really appreciate your time.
Thank you, David.
Thank you. And David, thank you for the kind words.
Well, thank you. Okay,
Thanks,
See you
Jack.
all.
That was great.
take care. Thank
Yes, thanks, Nick. Thanks, Jack. Thank you, Dave. Thanks, everybody.
you. Thank you.
See you, Anthony.
Take care.
You're going to be seeing these people.
Yeah, exactly.
Strength and conditioning. Just-
Awesome stuff.
They're ready for it.
Yeah, wow. It's great
Thanks.
info.
Okay, thanks a lot.
Thank you, Jack.
Bye now.
Thanks, Jack. Thanks, everyone.
Thank you.
Thanks, guys.
To everyone.
Thank you, Nick.
Thanks, Nick.
Thanks, guys.